the outstanding diagnostic characteristic of aortic coarctation is a high blood pressure in the arms and a low blood pressure with a barely perceptible pulse in the legs. The differential diagnosis hinges on this disparity of the blood pressure in the extremities and the diminished or absent femoral pulse. Since the oxygenated blood reaches the systemic circulation, the patient's color remains normal. Hypertension may lead to cerebrovascular accident. In addition, infection presents a constant threat to the debilitated patient, since nutritional deficiency may accompany the impoverished systemic circulation. When a short aortic segment is constricted, the clinical symptoms are absent or so minimal that they may escape notice, especially in childhood. In adolescence, symptoms of fatigability, decreased exercise tolerance, epistaxis, syncope, and coldness of the feet tend to develop and cause varying degrees of disability. In untreated cases, the lifespan rarely exceeds the 4th decade. Death may ensue from rupture of the aorta, bacterial endocarditis, or congestive heart failure. Efforts to relieve coarctation involve one of the most daring operations of the great vessels of the cardiovascular system. The optimum age for surgical correction is within the 2nd decade of life, according to Dr. Gross, and between the ages of 6 and 12 years, according to Dr. Hufnagel. During this period, the aorta has a high degree of elasticity, works with facility, shows little or no evidence of degenerative changes, and is in good condition for making a sizable anastomosis. The surgical procedure consists of the removal of the constricted region and an end-to-end anastomosis of the aortic segments. Where no surgical communication of the aortic segments can be created, the left subclavian artery may be joined to the descending aorta. Postoperatively, apparently, progress is spectacular. The blood pressure, apparently, in upper and lower extremities equalizes. The femoral artery pulsation is present almost immediately, and the circulation is apparently markedly improved. The most dreaded complications are infection of the suture line, resulting in leakage or dissolution of the anastomosis. There is an obliteration of the ductus by dividing the ductus and suturing the cut ends. This is a complete division of the ductus arteriosus. The heart, pulmonary artery, and aorta require complete transposition of the pulmonary artery and of the aorta. Where you have a Blalock Hanlon operation, the heart surgery makes for a right thoracotomy and exposure of the interatrial groove, the occlusion of vessels, the application of Satinsky type clamp, the section of both atria, and the removal of the segment and portion of the septum result in the repair of interstitial and interatrial septal defects, where the open method under direct vision is part of the extracorporeal circulation.